Hello, everybody. My name is Ella Auchincloss. I'm a member of the Health Systems and Transitions team. I'm here with my colleague, Pedja Stojicic, and I'm very proud to introduce our colleague, Bobby Milstein, who's the Director of System Strategy at the Rippel Foundation. He has worked at the Rippel Foundation since when, Bobby? 2007? 2011, right? And he is really our one of our great ideators. He leads our brain trust, and he is responsible for a lot of the work that we have done around thinking about how to make stewardship a normative set of practice, and what are the dynamics of the system that can enable stewardship and well-being to even be something that we aspire toward. In addition to his work with the Rippel Foundation, he's a visiting scientist at Sloan, at the MIT Sloan School. And he's got, I think, a very storied career. We're very proud to have him with us. Before he was with us, he spent some time at the CDC, and he will be telling you a little bit about his story. So this video is the second. It is being recorded for the second Stewardship Lab that we are having, which will debut in November. So welcome, Bobby.
Welcome, Bobby.
Happy to be here. Thank you.
And Bobby, can you just start by telling us a little bit of your story and sort of how you got to the place and where you are now, and sort of how you've landed around the idea that stewardship is a very critical norm and mindset for the people in our project?
Sure. I mean, like a lot of things, it's easier to see the logic when you look backward than what it felt like living into it. But I've always been sort of fascinated with the role of insiders and inside change agents. As a young person, I was really attracted to anthropology. I discovered later in college that I'd already completed an anthropology degree just because I loved it so much. And without even trying, I was just fascinated with the role of participant observation, partly being immersed and dedicated in whatever one's doing, but having enough remove and distance and, sort of a way of shifting consciousness to some degree to be able to see the, patterns of one's own experience.
Bobby, just for our audience, so you said like you spent 20 years in CDC. What was your role there? Like, what was your role?
Yeah. So I had a number of jobs, but one of the biggest and longest was I coordinated evaluation for all of CDC and was thinking about how we organize and the basis on which we evaluate the value of the work that we do. And this was in the turn of the 21st century, when we were really beginning to hold ourselves to higher and higher standards, but still an organization famously organized around disease and body part and population group. Yeah, most of the threats that we face nowadays, and you can think of them as the crises that are all over our headlines day in and day out, of pandemics that quickly turn into problems of mental illness and isolation and addiction and economic inequity, and then how does that fit with the precarious nature around climate catastrophe? These are really intertwined threats, and no one of them can really ever be addressed programmatically. These are not program and project kind of things. They require persistent change to create the conditions that are safer and healthier, and that produce the kind of lives that we want to lead together. And so shifting from that, there are some things that lend themselves nicely to bounded programs, but that's not the sum total of everything we do in this work. And so it helps to situate those problems into the systems that we all inhabit, and then begin to realize that those systems are vastly complicated, but we still have immense capabilities to see ourselves as stewards within those systems. And that, to me, has been the really imaginative and guiding work of what we do through ReThink Health.
So Bobby, so here you are in CDC. You're seeing almost anything that is happening in the country related to health disparities or improving health, and you're discovering that that's not enough, and we have to take it to the next level. And And what was that next level for you? Where did you
Well,
go
it
from
wasn't.
there?
I mean, let's be clear. It wasn't just me discovering that. Lots and lots of people across the field were beginning to recognize the limits of what could ever be done in a a program and a project kind of mindset, and they were looking for ways to make sense of the systems that we were a part of, and ultimately that led to different kinds of mindsets and practices and different kinds of sciences brought to bear. We you know often think about network science to look at relationships among organizations and who's connected to whom, and what does that equip us to do as a network that we can't do individually. There's a long list of things that could never be done by individual actors or even single organizations or even whole sectors. Many of the principal tasks that are necessary really need a far-reaching network of champions and supporters to get it done. Network analysis doesn't always take you all that far, because sometimes you really want to play out how lots of moving forces work together to either set us on a trajectory that is the status quo, or maybe steer the course of change in a new direction. And that's really what led to a whole chapter in my career on building simulation models that help people who see themselves as change makers in systems to play out the scenarios of what they think would make a difference, and really use that as a way to get more evidence and structure and creativity in the way that they think about their strategies, and ultimately what they do on Monday when they roll up their sleeves and try to make a difference. It often helps to be able to see the places that you think have the greatest leverage and pressure test those to see if they really are likely to play out in the direction that you're talking about. It's often way too costly in lives and money and time to learn only through trial and error. So we can practice and play out our thinking in very useful ways, and that's been at least one of those methodologies that are helpful.
Bobby, it seems like you were at some point looking at how to make interventions at the level of the system, and doing that modeling to understand what will move the whole system and not just one particular problem that you're trying to address. And that is such an interesting challenge, because it's the exact same challenge that the hospital leaders that we are working right now are facing, like how to manage an ecosystem that they're living in. So, just as a guiding question, what do you think? Like, what kind of system they are in? Like hospitals and hospital systems and healthcare systems. What kind of system they are in right now?
Yeah, I mean, one of the things that makes our lives complicated is that there are other people who also taking actions in the same environments where we work, and it is those interactions with others that creates both the possibility of immense influence, but it also creates possibility of working across purposes, and really not necessarily taking advantage of the relationships that surround us. And my colleague Stacy Chang had a beautiful quote that captured this in some ways, that healthcare organizations are planets that think of themselves as the sun. And so if we think about the solar system analogy, it's quite important to have at the center of our universe the thing that we most want to work on, and recognizing that there's a whole cast of characters who might have a role to play in making that happen. We start to sort of get diverted in our work and our thinking and our sort of the overall project of what we do in the world and what creates value can start to get distorted if we end up putting ourselves and our own institutions at the center of the story always.
Right.
And this is classic of a lot of bureaucracy, a lot of industrial era professionalism, is that we tend to think about the work that we were trained to do as immensely important, and it is. It's just that there's more to the story than ourselves and our institutions, and when it comes to the health and well-being of populations, it turns out to be incredibly grounding to put the human experience of thriving or struggling or suffering at the center of our universe, at the center of the work that we do. And once that is there, and we can begin to say our clear and unswerving aspiration is that all people and places should be thriving, with no exceptions, right? There's no reason that we couldn't organize a society in which all people are thriving.
So Bobby, just to clarify, so you're saying like there are a couple of really important metaphors. So you were saying that healthcare is the planet that sees itself as a sun. That's a big one. But then what you're saying that the actual sun is the human experience
Well-being of people.
Thriving in the communities and in places where they
yeah,
live.
and this is not a new message to leaders in American healthcare for the last, I don't know, 20 years. There have been a quest to try to put patients and families at the center of the work, to try to organize care in a way that is marked by shared decision making and really guided by the value that people have in the exchange they have with healthcare providers. Even our language on this is so complicated because we now use the word care like it's a noun, something to be distributed or in some cases denied. The original meaning of care was a verb, right? It was an exchange between healer and a person who was experiencing adversity, and that sense of a caring relationship is a beginning of trying to put the dynamic of a multi-party network, an ecosystem, as you said, a living ecosystem is really the means by which we exist and we make change in the world. And to the extent that we are not really thinking about whether that ecosystem is thriving and who's thriving in it and who's struggling and suffering, none of those things happen by accident. There are very clear patterns in the conditions that cause people to thrive and the conditions that consign them to often intergenerational lifetimes of struggling and suffering. So to some degree, that's the project of not only healthcare, but every industry, every walk of life has a role to play in creating a world where it's possible for all people and places to thrive.
So can you say more, Bobby? Because I know that we've spent some time with our teams talking about all of the things that are involved in the production of well-being and the role that healthcare plays in that. But that framework and how you talk about it and how we understand it, I think it's going to be really critical to the rest of what we do in this, among these stewardship labs. So I'm wondering if you can outline the elements of well-being and if you can contrast them to sort of the more common understanding around upstream social determinants of health, and share with us why you think looking at a portfolio of well-being might be a more appropriate way of understanding the role of the healthcare system.
Wow, there's a lot in that question, but let's take it in pieces. So I think the aspiration to work for a world in which all people and places are thriving, it's not just a romantic aspiration. That's a measurable criterion as well. One of the best measures in all of social science turns out, amazingly, our own overall life evaluation. To what extent do you think that, where are you on the scale between the worst possible life and the best possible life now, and maybe even looking to the future, what do you anticipate? If you ask those two questions, as Gallup does and has done for a decade or more, it turns out to relate to almost every other metric we care about: premature mortality, morbidity, healthcare utilization costs, workforce productivity. There are hardly any metrics that are not strongly related to people's self-perception of their own well-being. And one of the really kind of stark patterns that we start to see when we look at the yardstick of whether people feel like they themselves are thriving or struggling or suffering is that some organizations in the world are devoted to preventing bad things from happening, right? A lot of healthcare is kind of predicated on that thing. We all know at an individual level that a disease could run a bad course and can result in tragedy. Population health scientists, they can tell you from the first cigarette what's going to happen decades later, not the last one, right? It's the first cigarette that kills, not the last. And so we have an industry organized principally around preventing harm, and it's hard to see the full spectrum of what can happen when we're actually producing well-being, when we're producing the experience of thriving. And that distinction reveals a much wider spectrum of work to be done. So that's kind of the first part of a shift in my own thinking in this, is that, like, eradicating and preventing disease is not the full story of our work to produce health and well-being. It's part of it, indisputably necessary, but the story can't stop there. We have to actually think about, what are we creating that enables people to participate, prosper, and reach their full potential. And so now if we unpack that just a step further, everybody under adversity at any time might need help, right? We might need emergency care for acute illness or injury. We might need treatment for an addiction. We might need, homeless services. We might need unemployment and food assistance. There could be hazardous environmental spills that need cleanup. There are times and places under adversity where we need urgent services. And those are life-saving, life-altering experiences. But there's no amount of urgent services, no matter what, that can actually produce the feeling of thriving. That has to come from establishing what we call a set of vital conditions, things that are not just temporary and not just for a few of us every now and then. These are urgent, vital conditions that everybody needs pretty much all of the time. Think about basic needs for health and safety: clean air, clean water, enough sleep, routine health care, humane housing, enough nutritious food, lifelong learning, meaningful work and wealth, reliable transportation, and that sense of belonging and civic muscle, that everybody has a place in the world and needs to feel the experience of connection and love, and that they have something to bring, that they can contribute, that they too have a role in shaping our common world. These are basic elements of human existence, and we don't need randomized trials to know their importance. They're pragmatically important for our ability to reach our full potential, and they're better named in plain spoken, clear, normative language, right? All people need humane housing, and nobody who has humane housing would ever say, hey, I could do without that. Those people over there don't deserve it. Humane housing is a widespread norm in all communities.
Can I ask you a question? Because one could argue, and I'm channeling kind of like our audience here a little bit. Okay, vital conditions, that's important. But isn't that just a fancy name for social determinants of health? And if not,
there's much in common between a set of vital conditions and what we've called historically social determinants of health. There's a couple differences, but the first thing I would say is we could, anybody doing this work should be able to code switch between vocabularies that different organizations and different people doing this work bring. So it's much more important to listen for the understanding and the pragmatic meaning in words than it is to to have dogma about exactly what labels we call things. The concept of social determinants was really emphasized over the last several decades and only widely popularized, let's say, in the last few years. But the point of it historically was to illustrate that there's more to health than healthcare. And so thus came a category of things that were labeled importantly by scholars and observers of this work as social determinants of health. The trouble is that it's hard. That's a tough category because some of the things that determine our health, they actually determine other things than health. They determine our educational achievement. They determine our economic prosperity. They determine our sense of connection and purpose in the world. So the things that we say are social determinants of health, they determine more than health. Again, we're back to that, healthcare tends to put itself at the center of the universe.
Right.
And the term social determinants of health is the beginning of that slippage. These things determine more than health. In fact, in some ways, they don't always determine either because your job doesn't necessarily determine your future insofar as it could change, right? It is possible to organize and achieve living wages and that actually unlock the potential of your job to be a more rewarding experience than one that is damaging in some way. Or so these determinants are not necessarily, they don't dictate our destiny. Determinant is a social scientist's word for things that actually seem to have enormous influence. But if we're going to have a discussion with mere mortals and ordinary people who do this work, we need a more plain-spoken vocabulary, and frankly, one that's more specific about the nature of the work to be done. So there are social determinants of health, there are determinants of equity, there's upstream and downstream, there's prevention and treatment, there's all of these euphemisms that we tend to use, but none of them tell me as an ordinary person what I'm supposed to be doing. I'll take another moment to tell a mini story. For almost 30 years now, there's a famous report in the late 80s by the Institute of Medicine that declared that the purpose of public health is to assure conditions in which all people can be healthy. And for 30 years now, we have never really, as a field, reached consensus over what those conditions are. And so there's a lot of confusion in the field about when you say social determinants or when we say we should be assuring conditions for people to be healthy, exactly what are these conditions? So we need to, if we're going to roll up our sleeves and actually do the work of establishing those necessary conditions, then let's get brave enough, clear enough, pragmatic enough to state them out loud. We believe there's a set of vital conditions that everybody needs all the time, and they're the basis of widespread consensus. We don't necessarily agree on how to achieve them, but there's no dispute that all people need clean air and clean water and routine care and humane housing and that sense of belonging and civic muscle and the others that have been named here. So that's the amazing thing about moving our vocabulary closer to the work that needs to be done and closer to what's necessary for particular people and places to thrive.
So, boy, this is really interesting. So just in keeping with the metaphor of kind of healthcare imagining itself as the sun rather than a planet, and imagining that if our North Star or our sun, I guess to keep with that image, is everyone thriving, no exceptions. Given the outsized role that healthcare has played in the U.S. economy, and given the nature of the project that we're here to really figure out, right? This, like, how do we transition into something different? What advice do you have for our emerging stewards in just grappling with a status quo that does place healthcare at such a center? And what would you say to them about helping move their institutions into this different way of understanding?
Yeah, I think the first thing I would say is that it helps to always be part of a bigger story, right? I mean, one of the things that defines a steward is that they have purposes that are larger than themselves and their own institutions, and that they're constantly looking to build and distribute power with others in order to do work that nobody could do alone. And they use their resources, their wealth, their capacities, their talents, their technology to actually generate sustained long-term value. They're constantly looking for the value to be created through work and through investment and through networking. Then they are trying to use those resources for their own self-defined objectives. It's not to say that those narrower institutional purposes and personal passions are unimportant. They're just always part of a bigger story. And when we say that there's a North Star, we would just, at risk of taking the solar system, way too far, if the North Star of this work is the experience of all people and places thriving, then there's always a story to tell about how the work of an institution like a hospital fits in to the larger project, and where and how does that happen, and most importantly, to never let that aspiration erode down to some smaller objective that sometimes we get so immersed in the difficulty of our work that we choose the nearest outcome as the basis on which we declare victory. And so when someone comes in, to a hospital in need of the the swift orchestration of all of the talent and technology that's necessary to, in some cases, save that life. It's sometimes very hard to ask what brought that person into this ER in the first place. What was going on that created the need for such intense, urgent service in the first place? And I will say this is not a unique experience for healthcare professionals or for healers. This is true in addiction treatment. It's true for people who line up for food assistance. It's true for those that are involved in crime response. Every industry across the major areas where we have health and human services to try to support people in adversity, they're sometimes prone to alleviating affliction as the chief criterion for their work. But there is, again, more to the story, and this is where our habits of industry and what we pay for and what is considered valuable start to figure into the story here.
Can I ask you a question? Because this is really like raising an interesting challenge for me and attention. And especially in the context of this project, trying to explore the role of hospital systems. Because one of the questions we've been grappling with is like, okay, well, even if we have the North Star being all people thriving, how much actually is our role and responsibility in all of that? Because it cannot be everything, I assume. And it should not be everything, knowing some of the history of medicalization of things. But like, how do we grapple with that question from your perspective?
Yeah, it's a great question, and for sure, there's definitely role differentiation and role distinctions that are necessary. But let's build those role definitions off of an understanding of the common work that needs to get done. Right, the nature of what has to happen. And so when we think about just on the surface, just on the vocabulary that's used, if we define hospitals as providers of, let's say, healthcare, or maybe even modify it as providers of high value healthcare, which is already an impressive statement because historically they were paid to be providers of high volume healthcare. So even if we just accept that they were in the midst of a transition in payment reform that says you should be involved in providing the highest value healthcare, again, I would say that story is stopping too short because providing healthcare is also one way of participating in producing the conditions that are necessary for people to thrive. Right. So how do we not stop with the story of providing a certain kind of service into a certain kind of circumstance, but also recognizing that is part of the story of how are we participating with others in producing the value that we most want, which is not necessarily to treat people in a crisis. What we would most like to have is participating in a society that's designed with justice in mind, that's designed to create the vital conditions we all need. So it's obviously going to come down to the work that is done and expectations, but I'd say a minimal expectation for hospitals and healthcare professionals is to see themselves as playing, at a minimum, dual roles. You are both a provider of necessary services and a participant along with others in a much bigger project for us all. So that might mean that a hospital. Oh, sorry.
The operative phrase there then is in participation with others, right? So we spend a lot of time in our site projects thinking about what that actually looks like, how hospitals can actually show up and really explore that kind of deep participation in the production of well-being. I wonder if you have any, where I'm heading with this is, what is the role of a hospital as steward, right? What are the guideposts that we can offer our site partners around fulfilling this stewardship role? But if a hospital system takes itself seriously as being in participation with others in the production of well-being, where does that begin for you?
And so there is a tendency, an unwanted tendency, I think, in the end of the day, for hospital leaders to exert influence over their own industry mostly. But when do they show up and actually champion the agendas of others who are working to produce well-being? So to what extent does the hospital association show up and support the agenda of educational reform? To what extent does it support the conditions that are necessary for fair pay and environmental sustainability, the potential for people to actually play an active role in the democracy of which they're a part? We're now beginning to see examples where hospital leaders are just merely encouraging people to vote. Right, this is a basic right. The Vote ER campaign is, here we are in 2020, and it's kind of innovative for a hospital to encourage people to exercise their civic capacities. I heard an interview with a woman who's an emergency physician who said, I'm a trained emergency doctor, and I can handle almost anything that comes into the ER. That's what I do day in and day out. And I'm looking at the news, I'm reading the science, and I understand climate catastrophe to be an emergency for the population. And I have to participate in an effort to establish a viable future for our planet and its people. And so, understanding the ethics of emergency medicine, there was no way that she wasn't going to stand up as a leader in environmental justice and in a new ecological future for the planet. That's the kind of ethic that opens the possibility for healthcare professionals and their institutions to play roles that are not just about the delivery of healthcare, but the creation of conditions. Now, they're not going to always do it alone. They will do it in partnership and in networks, and this has to take root in specific places. But there's really not such a bright dividing line when you start asking, how are we participating and with whom to create the conditions that we all need to thrive?
That's such an excellent response. Thank you so much for that. I want to take a second now to sort of move us into a slightly different conversation, and that is, I want you to start to share with our course participants your experience of this ecosystem of thinkers that you're a part of that give you hope that moving in this direction is even possible. So, who are your compatriots? Where do you see these kinds of ideas really having purchase? And where have you seen industries really move in the direction of really creating long-term value?
Yeah, it's a great question, and I will say that I do feel optimistic that there's change to be made, but not without a lot of hard work. And I'll give you another example. So one of my favorite organizations is a group called Just Capital. They do something very, very simple. They merely ask large numbers of Americans how they think companies ought to behave. Right? What do you expect of a business in order to be a just business and to exist in a just marketplace? And there is nothing surprising about what they find in some very elaborate survey research. People expect companies to pay a fair wage. They expect them to treat their workers and create workplaces that are safe and healthy. They expect them to produce goods and services that actually are helpful and healthful for people and not harmful. They expect them to not pollute the environment and be good neighbors to the other people in their communities. They expect them to not, violate laws and have, sort of unethical governance of their corporations. So Just Capital doesn't just survey Americans about what they expect. They rank the top 1,000 Russell 1000 corporations on how well they're fulfilling Americans' expectations. And it turns out that the top 20% of companies that fulfill these criteria for just corporations, they make a lot more money than the ones at the bottom of the spectrum who aren't paying a living wage, who are producing harmful goods and services and so forth. And so we see industry-wide right now today variation in which companies are actually producing the things that are necessary for people to thrive and are proudly competing on their basis to deliver long-term value versus those that are, I would say, in a very, sort of questionable stance are trying to generate a profit while externalizing all of those harms onto somebody else somewhere else. That business model is breaking down, and the evidence that Just Capital shows tells us this is happening today. Corporate leaders are making decisions about how to run their businesses here and now. There's no reason to expect that hospitals shouldn't and couldn't adhere to that exact same standard.
I think
that's such a hopeful vision of what can be done, and it's kind of like it actually released this tension of, yeah, if you do good and act as a steward, that means that it has to come at some expense, which you're basically saying is not the case for those.
Yeah, no, this is a very pernicious myth that somehow to do good you have to sacrifice some yield. There is a growing consensus that there is both an upside benefit to investing in those things that are sort of in the orbit of these vital conditions. And even the most skeptical research that I've seen on this suggests that, maybe the upside may not be as strong as you think, but there's definitely a downside, less downside risk. And so even in the pandemic, those companies that paid living wages, for example, did much, much, much better than those that didn't. And so we just look at the last 6 months of charts that Just Capital has produced in the era of the pandemic and the downside risk that swept across lots of industries, including the healthcare industry. And not every company fares those troubled times the same way. It comes down to the network of relationships and the strength on which people see the value. If you predicate your value on a narrow foundation of delivering, high tech, high touch, high costly services, then that's exposure to risk, and that risk can turn bad in a hurry. This is not a case for altruism. This is mostly a case for expanding your value chain in order to deliver more value and compete on the basis of which you most want to compete, which is the well-being of people and places.
So we say that what you just said requires stewardship, right? So can you say more about how stewardship is a useful mindset in this creation of long-term value?
Yeah, I can offer lots of examples, but one that I carrying with me just because it was so unexpected, but it was happy. A year and a half ago, the Office of the Surgeon General said that they wanted to write a report on community health and economic prosperity. They wanted to explain that there was a mutually reinforcing relationship. When a population is healthy, the economy can prosper. But there's no way for people to be healthy unless they're participating in a prosperous economy. And so this is a marvelous message that I think a lot of us have wanted to put forward more clearly to the world, and to have the possibility of a Surgeon General's report saying that was really great. And it was directed at business leaders to say, you have a role to play in creating a healthier population, and those healthier people, no surprise, are going to end up driving more prosperous, more competitive, more effective businesses across the country. When you got in the room with the architects of the Surgeon General's report, they said, under no circumstances will we be able to use the term social determinants of health, because it won't be clear to these businesses. They're not in the business of producing social determinants of health. They're in the business of doing whatever their business is doing, and they need to understand that, that's what's most important to them. And so we started talking to them about the roles of stewards to create value in networks, in relationship with customers and supply chain partners and others. We talked about a way of not just stating this as a way of lowering cost and preventing disease, of which Americans are badly burdened by high cost and high levels of disease, but that wasn't the argument. The argument was you can unlock a lot of potential, trapped human potential, if you invest in these things. And what do we call people? What do we call businesses that act in that way? A good name of them. I mean, we could call them entrepreneurs because they're really savvy at business. We could call them social entrepreneurs because they're actually have a social mission, social impact matters to them. They would look good to the investors that screen investments by, social, environmental, and governance criteria. A better name, a more accurate name, is to call them system stewards, right? That they are people who are consciously seeing themselves as part of a system and stewarding that system toward negotiated goals. And so it helps sometimes to have a word for what you're talking about. And when we offered that word to the Surgeon General's office, they made it the centerpiece of the story. The Surgeon General has spoken about the need for all companies to have a culture of stewardship within their business so that they're on the right side of producing health and economic prosperity, not on the wrong side of undermining it. And, you know, I think we're past the era of an economist basically saying that, you know, that person's affliction is another person's paycheck. That's true if we're living in an adversity economy, when the most value is in essentially serving the demand of a population who is persistently struggling and suffering. If you predict that market demand is always going to be there, then sure, you can set up a whole paradigm, a whole economy that's predicated on saying, yeah, you know, I'm coming in with life-saving work at the last minute, whatever the affliction is, food assistance or healthcare, and say that's the basis of what we're doing. Our economy is actually capable of doing more. And if you listen to not just the Surgeon General on this topic, but if you listen to the industry coalitions left and right, that it is too risky to run an economy that is built on struggling and suffering people. It is much more promising to unlock people's potential. And so we would call that the pivot from an adversity economy to a well-being economy, where the combination of purpose and profit is what people are valuing, and that the value of the circumstances, the vital conditions that people need to thrive, is the thing that will accrue great value to institutions and whole value chain partners that are part of that. Hospitals right now in the year 2020 are not what I would call the most active proponents of a well-being economy. Oddly, you see this in lots of other industries more than you see it in healthcare. Yeah. But there's no reason that they couldn't move swiftly into that role and participate in the, I would say, the being midwives to the emergence of a well-being economy. And if we don't do it quickly, there's probably no amount of urgent services that can safeguard us from the catastrophes that we're enduring. So we've got a window of opportunity to do this, and there are fellow travelers, but it can't be done on the basis of a narrow marketplace around urgent services. It has to be done on a vibrant commonwealth around producing a well-being economy.
We're recording this on the 27th of October. This morning, we woke up to the news of yet another police shooting and protests in Philadelphia. We're on the eve of an election. We're working with leaders who are facing some, very drastic financial circumstances. I guess I'm wondering, as we wrap this up, what can you point to for our people as the next adjacent possible? I mean, what can you share with us that would be indicative of a stewardship move in this moment that we're in?
Yeah. I'll give you two quick examples. One is, that question about what do we do amid so much loss and adversity? What can we do to actually spring forward and convert that loss into renewal? That was a question that I was privileged to think through with about 100 organizations back in the fall, spanning all of the areas of vital conditions. We were asking folks, what do you see in this moment? What do you think is necessary? What could happen? And what we heard was a call for immense optimism. There is resilience in communities across the country. And what we need to be able to do is to harness that resilience in order to spring forward toward an expectation of all people and places thriving, and take those pivotal moves in the present that can lead to persistent long-term change for renewal over time. And I was sort of surprised by some of the contributors, but again and again, sort of network by network, we heard a common call for that sort of thing, and even from healthcare leaders who see that, in this moment of disruption in healthcare, we're learning about what can really be done with with uh, with remote contact, and what could be done to understand the difference between necessary care and unnecessary wasteful care. What could be done to participate in the centering of racial justice in this work. And so the springboard for equitable recovery and resilience is a sort of compilation of some of the optimism that exists in leaders across the country. And so that's kind of one resource that summarizes and begins to provide a window into the kind of work that's possible to spring forward, even in a moment, especially in a moment of intense loss. Another thing I would say is just to adjust one basic mindset of how leaders trained to be leaders sometimes think about their work. There's a sort of organizational science distinction between those leaders that are playing a finite game versus an infinite game. Right? Mm-hmm. Finite games, we all know what these are. They have a winner and a loser. They have a beginning, middle, and end. They have clear rules. Yeah. There are lots of games that are finite games in the world. Football and chess and
tennis.
These all have the properties of finite games, and there's a character of competition, even of leadership in a finite game. But there's also things that are infinite. Like, you don't win at healthcare. There's no winning at healthcare. There's always the practice. We call medicine and public health and other things practices for reasons, because they have no beginning, middle, or end. They have no clear finite rules. There is no winning of those things. There's the only thing you do is you stay in the game, and you're constantly adapting. You're constantly trying to do the things that are necessary to stay in the game and be relevant and to be useful. And it turns out that there are a handful, like a checklist of things that are necessary to thrive and to stay in an infinite game. This is not rocket science, but it begins with having a just cause. If there's a reason that you're doing this work larger than yourself, a just cause that will pull other people into your work with you, that will put you in relationship with others, that's the most valuable commodity. That's what allows you to persist through the dark days and the disappointment and the dejection that comes. It does not enough, obviously, to have a just cause. You need to have courageous leaders willing to get out of their comfort zone. You've seen what can happen when there's a vacuum of leadership in government. Sometimes people look to businesses to stand up for the values that they expect, and more companies and corporations are required to have a clear moral compass and to stand for that, because their brand is associated with it, and the ability to do work in the world with others is predicated on that. You have to have trusting teams. You have to have worthy rivals, it turns out. Somebody else, an innovator, an upstart, an insurgent in a market that finds a better way to deliver coordinated high-value care, makes the institutions that much better at doing it if they want to be relevant in that world as well. Mm-hmm. And lastly, you have to have a flexible playbook. You can't be devoted to competing on yesterday's business model if it's running out of gas, if it is limited, if it won't go anywhere. It doesn't help to be the last one trying to squeeze the last dollar out of a dying business model if you could be among those to create the new value under a new paradigm. And that paradigm is really, becoming clearer and clearer. It's not normative. And so the question is, the historical question is, for leaders in healthcare today, will they start to act like stewards in an infinite game to produce health and well-being, equitable health and well-being, or are they going to look like they were trying to get the last dime out of a dying enterprise? I mean, I hate to put it so starkly, but that's that's how historians will look at this.
I think that's an excellent place for us to maybe hit pause and to share that this playbook that you've talked about is really what's going to be at the heart of the rest of our sessions together.
Yeah.
That we understand that it is a mindset, it is a courageous stance, but there are some things that leaders can do to begin to not only model it, but to act into that way of being. And that's what the rest of this lab is about.